No,
My
I was
camera
seeing
is
you.
working?
Yes, yes. It's not working now, madam.
It's working?
No, it's not working, madam. Please, it was working previously.
Okay.
Okay, madam, it's working now. Okay, so good evening, everyone. We know that the World TB Day was observed on 24th of March, and we, the Indian Public Health Association, uh, as always, is an important stakeholder in the elimination of TB as envisaged by the WHO, the Government of India, and United Nations. So, with this background, we have organized a program in virtual mode on uh, for the World TB Day. Though you may say that it is deferred for 2 days, but we have arranged in such a day so that you can enjoy the program. Do give your valuable comments in the comment box of YouTube because we can see them and we shall try to answer them. The experts will try to answer them. So now I welcome Dr. Shanghamitra Ghosh, who is the Secretary General of IPHA. Madam, over to you, please.
Thank you, Ribu. Good evening, everybody. This is a very important day for uh, globe, for India, and for Indian Public Health Association. Uh, we are going to eliminate tuberculosis from India in 2025, and we are actually going back during the pandemic. So, whatever we have gained, we have to become again in that same wavelength. So, the TB day, the 24th March, when Dr. Cox has discovered tuberculosis bacteria. So that time we it was declared as tuberculosis day, and 24th was actually a very busy day for everyone, for us, because most of us were invited to Delhi. So weekend, we choose weekend, so everybody will enjoy this program. I welcome you all in this program, all the Indian Public Health Association and all the participants who are associated with the eradication of tuberculosis or NTB program. I welcome our three speakers, Dr. Taufik, Dr. Pauline Jan, and Dr. Radhe, and our organizer team, Dr. Ribu Basu and Dr. Kaushik Mitro. I welcome you all in this program. I'm not lengthening my speech because we are waiting for the speech of from the specialists who are working in this in India and already worked. So over to Ribhu. I wish all the best to this program. Over to Ribhu.
Thank you, madam, for the nice introduction. So, IPHE will be always an important stakeholder in this NTP as well as other public health problems of India because we are the largest and the most old organization of public health in India. So we shall be trying to do our bit in this effort. So now I welcome Dr. Pauline Chen of WHO, who will be deliberating her session with us. Over to Dr. Pauline Chen, and please add her presentation also. Thank you.
Thank you very much. So thank you very much to the organizers for inviting me to the Indian Public Health Association celebration of the World TB Day. Could you please present or project the slides? Thank you very much. Okay. So today I will talk about WHO's commitment to elimination of TB. But as you know, WHO has the global mandate from all member states and countries in leading the public health response globally on TB elimination. But today I will cover some definitions and milestones where we are in ending TB, where India stands, and where India's commitment is in ending TB, and where WHO India's commitment to the national plan. So to start, I would just like to remind everyone about the basic definitions. We are moving from control to elimination of TB, but there is also other concepts such as eradication. So what is control? This is when a disease agent is permitted to persist but reduced in a community at a level where it ceases to be a public health problem. We do control, for example, for malaria, for diarrheal diseases. In elimination, there has been various definitions and new definitions as well, including reduction of incidence of a specific disease to zero or to a specific definition in a defined geographical area by interruption of transmission of diseases. For example, we see this in neonatal tetanus or diphtheria, but we also talk about elimination of HIV, and of course, you know about elimination of viral hepatitis as a public health problem. Eradication is about termination of all transmission of infection by extermination of the infectious agent through surveillance and containment. And you progress from control to elimination to eradication. But we have only achieved this for really few diseases, including smallpox and poliomyelitis. What is the global definition of TB elimination? We move from, and we define low incidence countries, less than 100 TB cases of all forms per million population in a year. In pre-elimination, this needs to go down to 10 TB cases of all forms per million per year. But when we talk about TB elimination, this is really about less than one case, notified TB cases per million population in 1 year. The most recent global TB report gives us a scope of where India stands amongst all countries in the world. As you can see, India comprises 1/5 or 1/4 of the TB incidence. HIV positive TB incidence is about 7%, which is that India accounts for in the global burden. And India accounts for up to 1/3 of TB mortality. So whatever it is, India is very important in combating and ensuring that we end TB globally. What is the vision of being TB free? This is really several core indicators that is based on the reduction in the numbers of TB deaths compared to a baseline of 2015, a reduction in TB incidence rates compared to the 2015 baseline, and especially reduction of catastrophic costs due to TB. And this all contributes to our aim and vision of achieving universal health coverage for all, including TB. So as you can see, TB-free India targets already is aligned with the SDG TB targets of 2030. And in fact, the TB-free India targets is incredibly ambitious in that it envisions achievement of these targets by 2025. We wish, or we hope, to get to the deadline of reaching the 2035 targets. But the current global trend, it's really about reduction of 1.5% per year only. What do we need to do to accelerate the decline in global TB incidence? At the end, this is about moving beyond just business as usual. It is about accelerating, it's about optimizing, it's about leveraging. It's the systems approach that matter. It's about optimizing use of current and new tools that are emerging from the pipeline, from operations research to being implementing this in reality in field situation. We must ensure social protection as well. So how can we do this? We need to introduce and scale up new tools, vaccines, drugs, shorter proven treatment regimens. And we must guard against drug resistance TB or expansion of the drug resistance TB. And the use of more point of care tests and new technologies such as artificial intelligence and digital health. What is the progress of India towards ending TB till date? India has achieved the Millennium Development Goals. There is a reduction in the incidence by 11%. We know there is missing cases of 2.4 lakh. And we reached an additional 8 lakh cases in 2019. So our incidence is reducing, TB notification is improving in a sense until COVID-19. So here, let's have a look at the impact of COVID-19 on TB notification and the recovery. Here we present 4 high burden countries: India, Indonesia, South Africa, and the Philippines. As you can see, in Indonesia, in South Africa, and in the Philippines, they have not recovered. But in India, interestingly and encouragingly, there is recovery. There's recovery of notification rates. And this is very important. That means that in the field, the system is working. Your efforts as public health professional, as part of the TB champions, it's working. But you have to do more. TB notification over the last 3 years is presented here. As you can see, COVID-19 really did reduce notification. But when you look at it, interestingly, it rebounded just after the surge and the waves. And that means that the effort that goes into intensification and tracking back and tracing back people and making sure services exist at the most smallest block level and where patients can get their free TB services and get linked to incentives, that works. So to end TB by 2025, we have a target and we know this target. But where we are today, we probably need to accelerate even further. And we need to accelerate so that we can make it by 2025. There are some steps that have been taken by the program to overcome COVID-19 challenges. And these are all learnings for the public health community here in India, as well as the rest of the world. Systems need to work. And how do systems work? We need partnership. We need response from everybody, and everyone does have a role. And most importantly, we need commitment and political commitment and administrative directives. So the program did take advanced directives to ensure continuity of TB services. There's implementation of bidirectional TB COVID screening. There's a work on presumptive cases, ensuring that TB diagnosis remains functional and to piggyback COVID-19 onto TB services and strengthening health systems through this. There's also adoption of molecular diagnostics and to decentralize these kind of services at the block level. We always say that it's always difficult, but COVID-19 has proven that it is possible. But of course, we will ensure that sample transport, home base, and reaching out to communities and engaging communities will be also important. The Prime Minister in March 2018 committed to ending TB by 2025, which is ambitious and is 5 years ahead of the SDG targets. There has been a call for commitment from states and union territories to get TB free by 2024. And subsequently, there was a call for adopting districts and blocks to get to being TB free. WHO's commitment, it's about the Gatiman 109 districts. We committed to the government India to accelerate towards TB-free status in these 109 districts. And why accelerate? And why Gatiman? Gatiman will help India demonstrate how to reach the most unreached, the hardest unreached, and to be practical about it, and how to accelerate the achievement and the success and learn from other districts that have actually achieved better. It is a universal and is a systems approach to accelerating the TB response. And what is Gatiman? It's about galvanizing all actions for TB incidence and mortality reduction. And how do we do this? It's about accelerating novel interventions. There are some deliverables that Gatiman will do. It is about impact indicators. We hope to see up to a 50% decline in TB incidence in these 109 adopted districts by WHO. We have output indicators to have 1 lakh additional TB cases and 10 different models of care evaluated for effectiveness. Process indicators that includes chest x-rays and LTBI case tests and elected representatives sensitized, and to ensure that tools and field staff to monitor are deployed. This is the framework for the Gatiman. In order to get India towards certification, we will be working on countrywide scale-up from the 109 pilot districts or demonstration districts. We will include the use of new interventions. We will add field monitors to try to support better and improvement of quality of care. We'll have demonstration models and improve and in disseminating better knowledge management. Understanding how things work and does not work depending on the context is critical to get to elimination of TB or any disease elimination. It's about scale up. And we are basing all this work on our very strong network of almost 150 consultants, which will support planning, micro-planning, training, supervision, and monitoring. To get to TB-free, WHO is adopting these districts, blocks, and towns. So there are certain initiatives that need to be there including situational assessment, define what the local interventions should be, what to focus or prioritize, and what combinations are needed to catalyze improvement. And there will be a development of local roadmaps, hiring of people, and implementation. At the end, we will need to measure. And measuring progress will help us think how to scale up to the rest of the country. We are prioritizing aspirational districts, the most difficult to reach and the most neglected areas. We are avoiding, in our selection of districts, areas where notification is saturated, or the good performing districts, or districts that are already declared TB free. So you can see our strategy is about reaching the most unreached. And of course, it will be challenging. I'm calling you to action. As the Indian fraternity of public health specialists, of clinicians, of champions, we need everyone to be involved, and you all do have an important role to play in your locality to champion TB and getting to TB free. Thank you very much.
Sir, you can present now. Sir. Sir.
Yes. Good afternoon.
Can I share?
Yes. Can we have the presentation, please? Yeah, thank you. Can we have it full screen?
Good evening. Yes, we had a very nice presentation from Dr. Pauline Chand right now. So now our next speaker is Dr. Qazi Tawfiq Ahmed. He is a public health specialist on tuberculosis, and he is now working with the CDC, University. So over to Dr. Qazi Tawfiq Ahmed, please, for your deliberation.
Yeah, thank you. So first, I would like to thank IPHA and the team for the opportunity to speak, and Dr. Chan for setting up the stage. So can we please have the slides? Thank you. Thank you. Could you please put it in presentation mode, please? Thank you so much. So greetings from Central TV Division also. And today we'll be speaking on we can have the next slide. So we will start with what actually we are doing and what strategies we're adopting to reach the SDGs basically, and to continue to move towards elimination. So COVID hasn't deterred us, even though it had put us a decade back in terms of numbers, but that hasn't deterred us, and we are moving towards elimination. So just to start, after WHO declared TB as a global emergency, we started with the DOTS strategy in 1997, 2012 to 17, the first national strategic plan and the focus, and we went under the umbrella of National Health Mission, to put it in a very short way. 2020, it was renamed as with National RNTCP, which we all know. Revised National TB Control Program was renamed as National TB Elimination Program. The term elimination was first used this time. And of course, we know 2019, going a bit back, the TB Harega Desh Jeetega campaign with a lot of accelerators and boosters which we put in. So next slide. So 2012, a big landmark in history of public health of TB. So TB by GO was done with TB being unnotifiable disease. In 2015, it was added with an amendment and a public health action. So everything necessary that was needed to be done in public health orders was given. And finally, in 2018, a legal touch was given with some sort of penal provisions. So it was not just penal provision, it was sort of a carrot and stick approach. Even there were some certain incentives along with it. And also there were some penal provisions if we do not notify what are the provisions that are there. So this actually put a lot of gloves in the hands of the administrators. So this is how it started. So along with IPC 269 to 70, and create an enabling environment, not just for the penal provision, but also for improved notifications and increased notifications. Next. So the national strategic plan, coming to the national strategic plan 2017-2025, based on a four-pronged approach of prevent, detect, treat, and build. So basically, this is how we move towards elimination. Of course, we'll be talking of each of these blocks one by one. Prevention of emergence of TB, while diagnose and detect, and then we treat, and then we build, strengthen systems, build the capacity, and build an enabling environment. So we talk about this whole circles overall and create an overriding urge. Next slide. So we were talking about the key initiatives. So basically, we'll be talking one by one, starting with prevent. So TB preventing treatment. So we have so long worked with children below 6 years initial, and then move to 5 years, below 5 years for the prevention treatment, and the PLHIVs, people living with HIVs or the children living with HIVs. We now are moving to and expanding beyond it to the adults, adolescents and adults in each households, offering them TB preventive therapies. And intensively, and of course, India has been working aggressively with the newer TB vaccines. And then the point of care test, the skin test diagnosis, this might just be a game changer. And we'll have to wait and watch, of course, but this just might be a game changer. And this will form a point of care diagnosis of thing. Coming to detect, there has been a massive explosion of how we are expanding the diagnostics, NATs, 5-fold increase in NATs, what we used to do. And it is moving from, the state level to the districts, sub-districts, and even sometimes even below, along with, expansion of the CDST labs, the culture DST labs, as we call it. And then there are the newer initiatives like, the automated readings for X-rays, automated reading of LPAs, and then the new initiatives of which is being piloted. So based on the cough sounds, we actually try to find out presumptive TB, which is a new initiative. As we speak, it is being also piloted out across the states and districts. And right now it's just not passive case finding. So we are actually moving towards, moving to the community, looking for cases, trying to detect, and it is basically active case finding and intensive case finding in its truest sense. So, and then coming to the treatment, we'll speak as we go further again and again on this. We have the fixed dose regimens, and we have the short roll regimen. We have almost put a stop to the, the injection based regimens. And then most importantly, the differentiated care for T patients. So this is what we do, is basically we actually sort of triaging. So we find out which of the patients are actually, or TB patients are most needed of care. They need more care than the other patients. So we stratify, we understand there is vulnerability, and we take exceeding care and try to get more access towards healthcare for this type of patients. And then, of course, we are moving towards, decentralized care, moving even beyond the primary healthcare system. We are moving to below the subcenter and then the health and wellness centers. So we are moving treatment to in a more centralized, decentralized forms, and then build community engagement, the Jan Andolan, so the people's movement. So we are making it not only a government program. I think we are making it a people's movement. And there are a lot of inter-ministerial and intra-ministerial corporations, integrated health system approach. We'll come to one by one. And the biggest boost we got was the public sector engagement. And all this, the more case findings we get, a big chunk is provided the public sector, private sector as such. Next slide, please. So, for me, TB epidemiology India, a snapshot, if we say, this is according to the Global TB report, the estimated incidence of 188 cases per 100,000 and reported cases of 21 lakhs. So this is in spite of, the 2 years of a huge epidemic we had, the COVID epidemic we had. We have it in terms of gender, 60-40, 60% men and 40% women, children around 6%. And rural cases, we have almost 2/3 is rural and urban is around 33%. Tribal, around 10% of the cases are tribal. HIV positive, India is a country which is not, the TB is not fueled by HIV like some of the African countries. It is sort of a generalized epidemic. Epidemiology is sort of generalized. So, and also the drug resistance, overall, it's around 6%, new or old. So, and hard hit as well as reproductive age group, they're the hardest hit, 60% of them. So, what we need to understand here, this is actually a generalized epidemic and not fueled by some other disease. Of course, there are social interactions as such with the disease, but then this is sort of a generalized epidemic. Next slide. So progress towards ending TB. So, as we see, we are moving from 2010. Around 2017-18, we have almost reached the estimates. We can see the orange bar, orange line almost hitting the blue line. But then the COVID happened and we almost drastically fell. And it took almost a year, the whole of the year of 2020 to actually reach, where we were a year back. So this took, our decade of efforts and a lot of things. But then, as we said, that didn't deter us from the plans of moving towards elimination. We are trying to be on track, and in the next few slides, we'll see how we are actually doing it. And most importantly, if you see on the right side, we have the TB notifications from the private sector. So you see over a period of 2017 to 21, there was a dip again, of course, due to COVID, which happened everywhere. But then between 2017 to 21, we see, the cases of the private sector has almost doubled, from almost 4 lakhs to almost close to 7 lakhs in 2021. So that also is a big chunk that is actually driving the move towards notification and filling in the gaps, the missing millions, we're filling in the gaps, which is done mostly from the private sector. Next slide, please. Yeah. So diagnostic expansion, just the sheer numbers. If you see the microscopy, it is moving from 15,000 to 21,000. Just see the NATs, be it CB-NAT or True NATs, it has almost a 6-fold increase. This shows how the government is actively investing in molecular technologies, and we are moving away from microscopy towards molecular diagnostics. Culture labs, we had a fair share of increase in the culture labs also, and we're talking about active case findings. So these are filled by the mobile TB diagnostic vans, where we are actually going to the community and actually we are treating and finding cases and treating them in a more active case finding way, rather than what we used to do previously, just passive. No, it's not accepted now. So we move more to the field, find out the cases and deal with it in a more active way. And this way we have seen the TB testing has increased by almost 20%, between 2017 to 19. I'm just considering phase, and then after that COVID happened. So 17 to 19 we were like above 20%, and then we are trying to rise again. Also drug resistant TB, if you see between 2017 to 2021, so it has almost doubled. It has almost doubled in spite of the epidemic. In spite of the epidemic, it's doubled. So this we see a huge diagnostic expansion push that we have got. Next, please. So now we come to the, once where diagnostics are done, we move towards the TB treatment services. So as like I spoke a little, few slides before, the daily regimen, the fixed dose combination. So these are the things which are there in the program for quite some time, and it is being built and rebuilt, and we are strengthening it. The most important is simplification of the drug resistant TB regimens, the shorter regimens, and the injection regimens are almost they're gone. So and the newer regimens, the bedaquiline and delaminate based regimens. So this has actually all this in a collective way has given, improved the treatment success rate, both in drug sensitive TB as well as the drug resistant cases. Also, one more, we are talking about the differentiated TB care. This also had a big chunk to share. We are now understanding our vulnerable population. We are doing a vulnerable mapping of the patients in a better way, and we are treating them, we are tagging them, triaging them in a more better way, and we're doing it. Along with that, a lot also with TB comorbidity screening. The HIV patient, we're almost diagnosing almost 94 to 95% of our HIV cases, TB HIV, and diabetes also. The screening of it has also increased multifolds. The last couple of years, it has gone down a bit, but then overall, it is also really going up. In 2021, we have around almost 90%, diabetics who are TB cases who are screened for diabetics, which is very important. And as we now move towards the strengthening of the health system, the comorbidity screening and treatment is also very important if you want to have preferential outcomes and good outcomes in TB cases. Next slide, please. Coming to the prevention part of it. So as we said, so the not only the children below 5 years and PLHIV, we are now expanding beyond it to adolescents and adults and providing care. So also like expansion who are context pulmonary TB, then also this is fueled also by the new regimen of with rifampicin, INH and rifampicin, and we just have to have a better compliance against 180 doses of 6 months of INH against 12 weekly doses of INH and rifampicin. So this also forms a cascade, the way we are moving towards better diagnostics, the way we are preventing it, how we are preventing it using of CTB, and then moving towards TB preventive treatment. We have this new kid in the block, CTB newer skin tests, and they're very cheap. It's a make in India product, and it will be available very soon. So this will form, a major change in how we actually diagnose, how we actually treat, how we actually prevent. And this all actually fuels our movement towards TB elimination. All this, prevent, TB, treat, detect, everything. It's fueling. Next, please. So Nikshay. So basically, Nikshay, it is basically what it actually encompasses the entire national TB elimination program of what we are doing. What we are doing, starting from an enrollment of a patient to the treatment, how the patient is being adherent, whether the patient is comorbid, even how we are making the payment, even the DBT, the direct beneficiary treatment is, transfer is being, tracked through Nikshay. So not only we are enrolling the patient and offering treatment, and which is tracked, but also the social schemes, the direct benefit transfers which happens in patient's account, that is also tracked. And the outcomes, of course. So all these actually are very, very important, not only for monitoring evaluation, but the entire life cycle of a patient, be it drug sensitive, be it drug resistant. We have a tracking, we have a unique ID, we have a tracking, and that actually helps out bringing and understanding and monitoring the program very well. Next slide, please. So as we're talking, like Nikshay Poshan Yojana, which is basically done through the direct benefit treatment in patients' accounts. And this actually the patient gets 500 rupees every month is given till the duration of the treatment is completed. Some might have 6 months, some might have 8 months, or some might have more. Even in DRTB, we might have more months of treatment. So it is ensured that the program makes it certain that the account money reaches. And if you see the numbers, these are huge numbers, 1,500 crores almost. So it's a huge money that is being disbursed to the beneficiaries, and numbers might look big, and there are challenges, of course, but the entire process is automated. There is a linkage between the Nikshay portal and the banks, and done through the PFMS management system. So all this is, a chain of commands that is going on, and that actually helps the process to happen. So it's a huge and mammoth task which the program is doing now. So 1,500 crores is, not an easy matter, and it's one of the largest DBT programs that is happening today. Next day. So the most important part of it, the community engagement, and the most important way we are doing it is the state and district TB forums have been formed. This is being formed in each districts, and then the patient support system ongoing at the sub-district levels. So all these are being done. I'm trying to and during pandemic also, what the program had done also, there were self-learning courses also. So that also held a lot of capacity building, which ultimately led to development of TB champions. And it was a big leverage for the programs, how people is working, engaging these TB champions, at the survivors, as we call it, the TB champions, moving towards elimination. So they were like through NGOs, through CBOs, the community-based organizations, so all working in unison towards the movement. So it is a people's program, and without a community engagement, this mammoth task is just not possible. And we have the guidelines for it, how to do it. We have the know-how, and every year, it is being built. The pool of this TB champions is being built, and the services are being delivered. So it's all coming straight from the community, straight from the people who are affected most, and they understand it better than anybody else. Next slide. So this is something very unique our country has done, subnational certification. So many of you have actually been involved in it. So basically, how do we do it? So basically, states and union territories, they are claiming a reduction of every 20% reduction. There is some, there are some, there are some bronze, silver, gold, and then finally TB free. So there it is, and it is based on the 2015 incidents, what we had 2015. So based on that, and there is this is a verification is carried out by third party, basically WHO, and then public health association like Indian Association of Preventive and Social Medicine. So it's a very unique method of verification along with the second data analysis, and then awards are given. The first time we were like very skeptical what will happen. So when the first claims were done in 2019. So, and in 20, we saw like a total of 35 districts actually, and state and UTs claiming the awards. And actually gold was also handed over to Gurgaon district. So this year also, which was recently in the World TB Day, awards were given. So there were a lot of things that has happened, and this actually inculcates a sense of healthy competition amongst within the districts in a state and between the states. So how we move towards the elimination, there is a bar, and how we reach towards that bar, slowly progressing from bronze 20, then 40, then 60, and then move towards the elimination. So this is a wonderful way, and this is also being documented, wonderful way of how we are actually moving towards trying to certify the claims of the states and districts. Oh, next slide, please. Okay, so this is what actually, not only TB, it almost pushed all the treatments on all the programs in the back here. So if we see, the first time we were hit in 2019, you see first time the red, the orange bar, we are nearly, in 2020, we are immediately in the month of April where, pushed down. We are like less than 80,000 cases per month. So we really pushed down to a level, and it took almost a year, to reach the 2019 level. That is the orange lines we are seeing. The gray is what happened due to COVID. So this is what happened due to COVID in 2020. But if you see the yellow line, the next year, the COVID was even fierce. There were more deaths. But then if you see, the jump was better, and we reached the pre-COVID levels, even in a quicker way. This is because the first year we understood what it was. We built the systems. We knew what had to be done, and a host of things were done in COVID, so that not only COVID but also TB services were not hampered. We understood it better, and we'll see how we do it. But still, there was a 20% decrease in overall TB case notifications, down from 24 lakhs to 18 lakhs in 2020. But then we reached up to 21 lakhs in 2021. So we actually understand it now better how to deal with this, and a host of activities and things were undertaken by the government. Next slide. So what did the program do? Steps taken to overcome the challenges. What was that? So the most important thing was the bidirectional screening, which all of you know. The bidirectional screening was there. The TB screening for testing for all presumptive ILI, SARI, and COVID cases. Guidance document was there. And the laboratory had even the NATs that were used both for TB and COVID. So it was an integrated service that was given, and a decentralized model was used. The sample, we took a check at the sample collection and transport systems, the active finding campaign, and it was like being done even, when even due to COVID, the people were hit the hardest. But then these things were being done, home sample collections straight from the homes. And we are making sure that medicines were actually given, at least 1 month of supply of the drugs were given, and contact tracing was done efficiently. So this all were like things done, because when the first time COVID hit, we were really down, as we saw the graph. But second year, we saw that we are actually fighting it more aggressively and reaching, the pre-COVID levels and even above, in a better way. So these were all the things of this public health actions we did, and we understood, and that was the effect was. Next slide, please. Yeah, but then this COVID also gave an opportunity for a long term, being a respiratory disease also. There were like certain behavioral changes, that the mask wearing, the social distances. This is like, the social distancing part of it. These were all very important, and I would say the good effects of COVID that actually gave us, the learnings that it gave us, the good learnings it gave us. So first year also, when we go through the PPEs and everything, we were actually importing a lot of PPEs, from abroad. But when the next cycle hit us, the next COVID cycle hit us, actually, the COVID pandemic, so we were actually much better prepared, and we were actually, exporting it now to a host of other countries. So this is what we had done in that year, preparation, the preparedness for a pandemic. So these are things that we actually wanted to we learned and we understood, and this is what helped us in the long way. The third wave proved it, actually. The dedicated infection and hospital isolation wards. So these are the long-term, good effects that we actually were able to do. The expanded diagnostic, TrueNat, CBNat. I mean, it was used both for COVID and TB bidirectional screening. So all these things, holistic things, holistic way we could actually combat, TB and COVID. The wave, I mean, what it actually did was, what we actually did was the post-COVID follow-up for TB patients for every 6-month interval, and then the opposite also, the sequelae of the vice versa. Next slide, please. So to sum up, the key to sum up what we actually said: prevent the COVID appropriate behaviors. We trust, in a better way. The TB preventive treatment has been started and is expanding. How we were working with the AICs and the IPCs and the health facilities, and the Jan Andolan, the people's movement. So this all actually, the prevent part of it, it got a huge push. Detection also, we moved to below sub-center levels, to the health and wellness centers. So they were not only providing RCA services, so they were providing a lot of diagnostic services, and upfront NAT testing was done, also expanded, and vulnerability mapping and active the differentiated TB care, which we were talking differentiated TB. We were understanding our patients, and vulnerability mapping was done, and we know how to actually focus on what, and then get better outcomes. The daily regimens, the fixed regimens, and then the shorter regimens, the newer drugs, bedaquiline, delaminate, and then the differentiated TB care again. The build part of it, we talked about the private sector engagement. So yesterday only we had a huge, a big corporate pledge. So a host of corporates and corporations actually, the way they are also working hand in hand, and we saw the huge private sector push. We also saw the data, how it is contributing towards total country notifications. And all this treatment we're talking about is just, not for any public or private, but both of them together. So any TB patient, public or private or anywhere, we take it together. The digital interventions of it, the last 2 slides will speak of it also, and the community engagement part of it, as we spoke in the last slide. Next slide, please. So so we talked about this multiple times, but then again, going forward, the community-based health screening. So the CHOs. So basically, along with the ASHAs and the ANMs, there will be a line listing, and they will be providing, they are doing line listing for almost everything. So will be a comprehensive service, just not TB, like TB and diabetes, TB and leprosy, TB or any other, NCDs, non-communicable disease. So this will actually be a package of services. And what we are doing is moving at this health and wellness centers below sub-center levels is actually, we are actually strengthening the systems. We are strengthening the systems to have an overall package of delivery, to provide a diagnostic, promotive, curative, services for TB, the awareness services, and NICSHA registration for all health workers. So basically, notification below. So this all this way, we are moving in a much decentralized. The care is being decentralized, and more a package of services is being provided. And overall, what we are doing, the overall objective with the strengthening of health systems, and that is what is basic. We are not moving vertically. We are trying to strengthen the health system as we go along. Next slide, please. So NICSHA, we talked, and there are a host of things that are being done, So X-ray readings through artificial intelligence and AI solutions, the reading and interpretations of the line proboscis strips. So that will also, improve our things to almost 50%. And then what we are talking, we have the data in NICSHA, and this AI-based artificial intelligence system will actually do a stratification of TB patients with risk. We are categorizing the risk, which patients are more at risk, which patients are less at risk. And this is how we are actually, we know what we have to care for more and less, something like that. And then we have the AI solutions that identify features of cough sounds, based on the cough sounds, we can actually understand the presumptive TBs, or even before that, we have almost majority of the cases are not symptomatic. So this will actually might be a game changer. So this actually, sort of completes the cycle. If we see that we have the preventive services, we have the treatment for latent TB, we have the drugs, the new drugs, rifapentine, and then we have expanded beyond this children and PLHIV. We have moved to the household contacts, and then along with this, if we can do we have moved the services, decentralized care at the health and wellness center level. And with all this, actually, it forms a complete cycle of, prevent, detect, and, the treatment, every cascade of it completes the circle, a complete range of services, we should say. So next slide. So this actually is, 2 days before we had World TB Day, and two things we did not touch upon is, one is the prevalence survey, and then the annual TB report has been released, which of course is available on the website. So this is how we are actually, fighting towards and moving towards elimination. And we are confident that we actually will meet our 2025 targets. And of course, then TB harega, desh jeetega. Thank you. Over from my side.
Thank you, Dr. Qazi Tawfiq, for the excellent deliberation. You have been always a mentor for all of us, and like with this holding of hands, maybe we shall be able to realize the dreams of many policymakers and crores of Indians to eliminate TB. So thank you for the deliberation, for an excellent technical session. So
Thank you, Dr.
Now we can move to the next speaker. So I would like to introduce none other than Dr. Kiran Kumar Rade of WHO India, who has been one of the masterminds of various aspects and strategies of NTP, including the subnational certification, of which the whole of India is very proud of, because it is one of the largest community-based survey programs of the world, triangulated by secondary data sources and also other techniques. So the stage is all yours, Dr. Rade. Thank you for joining us.
Thank you, Review, and thank you very much for inviting me for this important deliberation and discussions. Can you allow me to share the screen? Is it visible?
Yes, sir. Please tell me.
Are you going to project the slide, or will you allow me?
Hello, sir.
Are you going to project the slide, or can I project?
Sir, please project, sir. It will be under your control then.
It's not allowing.
Okay. So if you click the share, and then the shared link is there below the screen.
Is it visible?
It will be visible just now. Okay. Yes, sir. It's visible now.
Okay. Thank you so much. And thank you, our previous speakers, Dr. Pauline Chan, already alluded to the WHO India's commitment vis-a-vis the Government of India's commitment for ending TB in India. And Dr. Tawfiq very elaborately described the interventions which are ongoing during the program, in the program, and how everyone is contributing. I would like to focus on the technical aspects. This national strategic plan is very, very clear, and all the four pillars Dr. Tawfiq mentioned that is a strategic plan, but I would like to focus on the technical and operational aspects of what all things are needed to be discussed further and need to be addressed in addition to the overall interventions which are happening in the right direction. So I'll talk about the challenges in TB, the possibilities and potential, what all interventions are there, and how we can actually solve this jigsaw puzzle if we really want to end TB in India as per the targets. If we look at the India's journey, the annual percentage change in notification in the first half after the complete coverage of dots in the country between 2005 to 2012, the notification was stagnant at around 1.4 to 1.5 million. And later on, due to various interventions like notification, private sector engagement, there is an increase and we have reached up to 2.4 million in 2019. And the trend was continuing. So we can say India was, or rather today also we can say India is on the right track. But the golden question is whether we will be able to achieve the ambitious targets as per the National Strategic Plan, which is 90% reduction in mortality and 80% reduction in tuberculosis incident as compared to 2015 figures. So we did the mathematical modeling when we are revising the national.
Sir, please, can you put the slides in full screen, sir? It's not visible in full screen.
Is it full
Thank
screen
you,
now?
sir.
Okay.
Yes, sir. Thank you, sir.
Thank you, Rivu. And when we were revising the National Strategic Plan, it was very much methodical and based on the evidences, based on the mathematical modeling as to if we continue with the current interventions, which have been mentioned by our previous speakers also, we will not be able to achieve. If we look at the scenario 1B, which is the topmost line, then we will not be able to achieve much. The reduction will be just hanging around 40%. If we add some of the interventions like rapid molecular diagnostics and increase the access to the diagnostic services, we may increase that reduction to around 55%. If we introduce TB preventive treatment and vulnerability reduction measures, including the comorbidity management and similar interventions, then we may reach up to 68% reduction. And if we introduce the airborne infection control in real sense, if we improve the living conditions of the individuals, if we invest into poverty reduction, then we may reach up to 75%. But still, we are not hitting that target of 80% reduction in incidence. And that's where the role of vaccine is very, very important. But all these things were based on the infectious disease modeling for tuberculosis. This is regarding the tuberculosis incidence projected. If we look at the mortality, that still is very high. This is the India estimate since 2000. The case fatality ratio is hanging around to around 20%, reducing to around 16% since last few years. But still, there is a lot to do, we have a long way to go. And for this, it is important that our interventions should be addressing both these things, the mortality as well as the tuberculosis incidence. Now, what are the basis? If we see, tuberculosis is not a simple disease with a progression that, okay, once the susceptible individual is infected, then in a linear manner, it progresses towards the active tuberculosis or active disease. It's not as simple. As we can see, the infected individual can just be normal and the infection can be eliminated on one side. At the other end, we can see it can rapidly progress to the acute tuberculosis and it can be clinical. But interestingly, some of the individuals will continue to remain infected latently, and in due course of time, the infection may get eliminated, or there may be slow reactivation, there may be a rapid reactivation. Importantly, also, it is a cyclic disease. It may reappear again and again. 2-3 episodes are not uncommon. So, if we look at the individual level, it starts from the TB eliminated to latent to incipient TB to subclinical TB and acute tuberculosis. So this is at the individual level, and that's what it makes very difficult to define the intervention, design the intervention, and capture all sorts of individuals with various stages of the disease. When this was at the individual level, what can happen? It could go either way. But if we look at the counts at the population level, then we can measure the primary infectious state, the pathophysiological outcomes, and the observed outcome. And all these are going to be very, very helpful for measuring the progress at the population level. We'll not go into the details, but it is important to measure this, count this at the population level. Then only we'll be able to identify and ensure that we are on the right track. For a given geographical area, this is what is important. You can see all the population, not the whole population is susceptible. Part of it would be susceptible. Not everyone will be exposed. Those who are exposed may not be infected, but those infected may go into latent TB. Some of them will develop subclinical TB. Partially, some of them will go into the acute tuberculosis, and despite treated or not treated, some of them would continue to die, and that is the unfortunate thing. And in the whole story, there is a subpopulation which is more vulnerable and where all these rates will be much higher. So if we really want to design the interventions in such a way that we can measure the impact at a cross-sectional level, a static model at the population level, all these subset of population needs to be measured, and we have been successful in doing so, not at the district level fully, but at the state level. We attempted the national prevalence survey, and this information is coming out very, very clear that 1/4, we used to say that 40% of the Indian population is infected, but now we know that in adults it is around 31% at national level, and at if we consider children also, it is estimated to be around 22 to 25%. Likewise, we need to measure these things at the if not at the district level, at least at the state level, and then we can allocate our resources judiciously. This is one more aspect which is hindering our progress: subclinical tuberculosis. This is the information from the tuberculosis prevalence surveys across the world, especially from Africa and Asia. If we look at the crosses which are there, that is the prevalence level. Of course, we know that the burden of tuberculosis is different in different countries, but irrespective of what is the level of tuberculosis prevalence, it can be as low as less than 200 in Thailand. It can be as high as almost more than 1,000 in Philippines or Cambodia. But irrespective of that, one thing is coming out very, very clear, whether it is Africa, Asia, or overall in the world. The proportion of subclinical tuberculosis, means those which are not symptomatic, in amongst the pulmonary tuberculosis, it ranges and hangs around at 50%, ranging from 40 to 70%. And if we bank upon only symptomatics to be tested for tuberculosis, we will lose at least half of these individuals, and they would continue to infect. And this is the danger which we are seeing if we follow only symptomatics to be tested as a screening and testing policy. Now, if we use chest X-ray, which is the only way we can currently identify these subclinical tuberculosis patients, those who are symptom negative and X-ray positive, at the population level, that proportion is around 10 to 20%. It varies depending upon the burden, but if 10 to 20% of the population can be identified during the screening as symptom negative but X-ray suggestive of any lesion on the chest X-ray, this is how we can actually proceed. But the golden question is, can we chest X-ray the whole population? Will it be feasible? Maybe, may not be today, but at least in the vulnerable population with the handheld X-rays devices coming up, it may be possible in near future, and the program is thinking in that direction. Now we think that we know a lot, but sometimes we don't know some of the things. As we saw in the disease progression, there are many questions. As I said, is the whole population susceptible? Is the susceptible population vulnerable? Whether the vulnerables do get exposed? All these questions are important, but also important is what is the rate of change in those particular proportions, and that is the information that is needed if we really want to measure the progress, because we will not be able to do prevalence survey every now and then. So for mathematical modeling and also prioritizing the interventions, what is needed is the questions which will be from the public health angle suggestive of the action. So can we reduce the population susceptibility? Can we reduce the vulnerability? Can we reduce the exposures? Can we reduce the infections? And of those infected, can we prevent the acute tuberculosis? That is the clinical one. Can we identify subclinical TB? Can we eliminate latent TB? And of the latent TB, can we prevent reactivation? Because TB preventive treatment may be very little, but even if it is 1 or 2% failure of TB preventive treatment, that will be important, and that reactivation needs to be measured and can be prevented with, say, some of the vaccines. So these are the questions that we need to answer and suggest the actions for correcting those issues at the population level. One of the things that has come out very consistently throughout all the prevalence surveys in the country is health seeking behavior. 50 to 80% of the symptomatics do not seek care, and of these 60% ignore symptoms, more than 15% do not recognize it as illness, 10% get self-treated, and 10% cannot afford. At times we say that many individuals don't seek care because they cannot afford, but that's not true. If we see, more than half of them just ignore the symptoms, and that is a worrying thing. But this is a consistent finding which is coming out from the Gujarat Prevalence Survey in 2011, and now the recently concluded National Prevalence Survey everywhere across the country. And those who are seeking care, where are they going? We're saying that majority of them goes into the private sector, but that proportion is also reducing. Those who are seeking care in either place, we need to ensure that these services are available. So what is the implication? The implication is missed opportunity to diagnose. If we miss out on the symptoms, if the people do not seek care, then what will happen? There will be delay and there will be continued transmission in the community. And of course, even if they get diagnosed and they get treated, the outcomes will be poorer. And the multiple providers is another issue which is coming up again and again. At the national level, we see around 3 providers being visited by an individual before the patient gets diagnosed, and that leads to further delay and continued transmission. Out of pocket expenditure, the cost incurred is also another thing, which is the one of the 3 impact indicators for measuring our progress towards ending TB. And if people continue to shift from one to other provider, the out of pocket expenditure and its contribution to the catastrophic expenditure would continue. Disability and mortality, of course, if the health seeking behavior is not improved, if people do not seek care on time, then the continued disability and mortality will be a challenge. Another issue which has been identified is the undernutrition. It is very well known that if the body mass index is much lesser, the prevalence can be as high as more than 1,000 per lakh population. As the BMI increases, the rate of prevalence of tuberculosis decreases, and in the last one, the obesity of more than 40, it is almost nil or negligible, we can say. But that cannot be the excuse, or rather we should not be promoting, because then it would be, if we promote to increase BMI, of course the non-communicable disease may arise. So that is not the intention, but at least bringing them into the normal BMI should be the aim. And we need to ensure that the nutritional assessment is done for every tuberculosis patient, and that is how we can actually reduce the prevalence and incidence in long run. Also, the TB outcomes are very adverse when it comes to low BMI, and there is high recurrence also. So we need to address this particular issue on priority. Giving 500 rupees per month is not going to suffice, and we really need to ensure that the nutritional status is corrected. Otherwise, there will be very high mortality among this tuberculosis patient with low BMI. Another thing that has come up from the national prevalence surveys, operational efficiency of the smear microscopy and liquid culture both is much lesser. And the rapid molecular testing, whether it is GeneXpert, we call it CBNAT in India, or whether it is TrueNAT, that's the way to go ahead. And we need to prioritize and shift to rapid molecular testing for diagnosis at the earliest, and program is planning in this regard. For follow-up culture, long-term follow-up is there in the treatment technical and operational guideline, but it needs to be ensured, and there, rather than smear microscopy, liquid culture should be utilized across the country. And how we can do? We can think of outsourcing this, because it will be huge numbers, millions of individuals would be requiring liquid culture. Private sector can be considered as a resource, and we can purchase the services from the private sector. Now, few of the things which our other colleagues also said: screening strategy, clinical algorithm. We saw the role of chest X-ray. If we do not use chest X-ray as a screening tool in the clinical algorithm, we are likely to lose half of the patients. So in our testing strategy, chest X-ray must be included as screening tool, and the diagnostic test has to be rapid molecular test, whether it is passive case finding. In the intensified case finding, the key populations at the health facilities, institutions, communities, or different population, whether it is healthcare workers, the PLHIV, diabetes mellitus, hypertension, tobacco, smokers, malnutrition, COVID-19 follow-up patients, silicosis, all these conditions need to be identified, and intensified case finding effort needs to be encouraged at the facilities and institutions. Vulnerability assessment, doing it periodically in the or at least quarterly in this vulnerable population, and in general population at least annually, is the way forward, and program is seriously considering that, and many states are actually working on it. Presumptive tuberculosis examination rate. This is the most important indicator if we really want to achieve. India has shown that in a day, even 2 million tests are possible. The testing is very similar. It is also RT-PCR, whether it was COVID, and now whether it is GeneXpert or the TrueNAT, that is also a PCR test. And we should be able to reach to that level of COVID response. And then when we look at the modeling, unless and until we reach 4,500 per lakh population presumptive examination rate, we are not likely to hit and achieve the reduction of 80% incidence. So in general, as a thumb rule, we can say annually 5% population need to be tested for tuberculosis. This I will not complicate, but this is a new mechanism that has been introduced for COVID vaccination. This is e-rupee mechanism in which the services can be procured from the private sector using the information technology, that a simple SMS or a QR code goes to the targeted beneficiary. The beneficiary can go to any of the places, and we are thinking of prioritizing this particular service for chest X-ray, for diagnosis, for liquid culture, or anti-TB drug vouchers for the private sector patients, and TB screening as a package for the corporate sector to make the workplace free of tuberculosis. So these are some of the ideas which are actually in the oven, and if followed, we can really scale up the interventions and purchase the services and make it available to the individuals at a click of a button on their mobile. There are few treatment realities. Digital adherence technology, though initiated almost 9 years before, 10 years before, still the coverage is not enough for impact. It's less than 5%. We have changed to daily regimen from the intermittent regimen. The recurrence is likely to be much lesser, but larger study is required in this direction. The sputum collection and transport system is not fully operational across the country. The testing capacity and requirement is suboptimal in terms of monitoring also. And these are the issues that needs to be addressed, and then only we'll be able to ensure that the impact of these interventions can be achieved and the fruits can be reaped. If we do not do that, we'll continue to face the issues in the tuberculosis treatment under the program. These were some of the interventions which we saw at the programmatic level or the patient level or the presumptive level. But if we want to have the impact at the population level, then there are certain factors or predisposing factors. For example, alcohol use, diabetes, HIV, smoking, undernourishment. All these factors are very, very important. And if we do not address, we can look at undernourishment. The proportion of tuberculosis patient that the undernourishment is contributing is humongous, and so similar are the rest of the contributors. This is the population attributable fraction, and unless and until we have the interventions at the population level, we will not be able to achieve the desired impact on the incidence. And there are opportunities. For example, indoor pollution is so important. Having clean fuel for cooking inside the house is so important. And we have the interventions, for example, linking every individual household with the Ujjwala Yojana, livelihood programs for ensuring that the people are not below poverty line and they get enough nutrition, social protection measures like Nikshay Poshan Yojana, PMJ, e-rupee. Living conditions in slums can be improved with National Urban Mission. The Poshan Abhiyan or the National Nutrition Mission can be leveraged upon for ensuring nutrition, not just at the patient level, but at the population level, so that the vulnerability is reduced and the conditions can be more suitable for reduction in tuberculosis burden. Prevention, Dr. Taufik has covered in detail, but the time has come to scale up and monitor TB preventive treatment. And of course, if we do not plan for vaccine introduction now, then we may miss the bus, and starting or thinking in last 2 years of 24 or 25 will not suffice. Country needs to prioritize. There are vaccine candidates available. We need to make a case for emergency use authorization and go for example, one of the example is recombinant BCG, which has the component of not just the BCG, but also the wild strain into it as a recombinant vaccine. And these are the opportunities we need to explore and introduce in the classical implementation research mode, maybe community randomized trial, but we need to consider it, and we should not wait for the last year to come when we don't have anything and then we think of vaccine in emergency. The emergency is now and we need to work on it together. Another big role I can see is the social mobilization in real sense. Many a times we say we do create do some awareness activities, we'll do this, we'll do that, but many a times it doesn't happen on the ground. Sensitization of the political leaders is very, very important, whether right from the member of parliaments, MLAs, MLCs, uh, Panchayati Raj at the district, block, taluk, and the Gram Panchayat level is very, very important. 15 Finance Commission recommendation are on board, and the government has announced $10 billion for next 4 years. That is 70,000 crores. And this is something which needs to be utilized for local planning by the local bodies, both in urban and rural areas. Local resources, local care and support and advocacy is what is needed. Local monitoring, testing, follow up. And for that, village wise presumptive examination rate for the testing is the starting point. We need to identify villages where there is no care seeking. We need to identify where there are more patients also on both the sides, and that's how we can move ahead and involve the panchayats. And we need to sensitize all of them. We need to utilize the workforce which is available for this, and it can be done by using technology, including the INSAT, EduSat, and the mechanisms like iGOT, All India Radio, and things like that to reach out to the masses. We usually talk about incidents, but the mortality is important, and we have seen that if we utilize and introduce around 14-15 very simple parameters, then we can reduce mortality by 50%. And for that, program has introduced a guideline called differentiated care and pulmonary rehabilitation, but this is not happening on the ground. That's where we really need to join hands together and make it happen. What are the components? Nutritional assessment, measuring height and weight, calculating BMI is not a big deal. Measuring clinical parameters periodically, temperature, pulse, BP, respiratory rate, pulse oximeter. Maybe 4 years before it would have been difficult, but nowadays pulse oximeters are available everywhere. Identifying icterus, edema, and simple investigations like hemoglobin, CBC, HIV, random blood sugar, chest X-ray, hepatitis C. These are the tests which are available in the periphery, even at the health and wellness center, the sub center, and needs to be introduced. Then one thing is missing is long-term follow-up using liquid culture. So during treatment and after treatment, if we introduce these simple parameters, clinical parameters at baseline and periodically, and ensure referral linkages after treatment also, then we'll be able to reduce the mortality. AI and ML, Dr. Taufik also covered, but the potential is so huge that we can really screen the population. The program has developed its own chest X-ray based artificial intelligence for automated reading, and it can be used in the community screening as well as hospital screening. Whatever population we are able to X-ray, we really don't need a radiologist on the ground, and it can be automatically read by this AI. Similarly, another tool that has been developed by the program is the risk stratification of TB patients. It's not yet fully ready, but it is ready for pilot, and this will be helpful for the interventions, identifying those individuals who require special care. Last month, there was one more artificial intelligence tool that is developed, and initial findings are very, very encouraging. Simple cough-based or voice-based screening tool has been developed by the program, and if it can be used and made available to the population, we can screen the population at will, at very, very periodically, and the total yield that we'll get to identify every individual who is likely to have TB is going to increase many-fold. This is going to be revolutionary. And also the interpretation of LPA strips may not help additionally for having more patients, but it will be helping in reducing the HR workload, I can say, for the microbiologist and the laboratory technicians. So these are some of the interventions which are important from the impact perspective, and based on the contribution that each of the intervention can have in reducing the mortality and incidence is what we are looking at. So I would like to acknowledge my colleagues, senior colleagues from WHO India, Central TB Division, ICMR, and all my development partner colleagues and donors. Thank you so much. Back to you, Rob.
Thank you, Dr. Rade, for the excellent presentation. So I think the speakers one after another built up the stage, and there was not much of an overlap. So from a global perspective, we have been able to come to Indian perspective with the Indian innovations. So thank you. Thanks a lot for the excellent deliberation. This will be most helpful to us. And now we have got the huge privilege of having all the three distinguished speakers on stage, along with our Secretary General, Madam Dr. Sanghamitra Ghosh, and our CC member, Dr. Kaushik Mitro. So I now give the stage to Dr. Kaushik Mitro so that we can discuss about how IPHA can act as an important stakeholder in this NTEP in the coming years, and how can we join hand with each other as a call for action in this stage. Over to Dr. Kaushik Mitro.
Thank you, Dr. Rivu. And I thank all the speakers, Dr. Pauline Chan, Dr. Kazi Taufik, and Dr. Kiran Kumar Rade, for your excellent deliberations. Before going into this topic, I'd just like to ask one of the questions asked by our audience, Dr. Shukanto Bhattacharya. Will this handheld X-ray chest be something like MMR, that is mass miniature radiography? The thing that we are talking about, artificial intelligence in using chest X-ray, he is asking that will it act like something like that mass miniature radiography which were in the earlier years? Over to the speakers, please.
Can I take this question?
Yes, sir, definitely.
Mass miniature radiography was a very small film, traditional film, the size of we can say our pocket or a wallet, and that used to be seen with a lens. The aim was to reduce the cost by reducing the size of the film, and that was mass miniature radiography. The handheld devices, chest X-ray devices, which we are talking about, is similar to if you have looked at the dentist when they take the X-ray. That is something which is portable. So rather than handheld, probably that may not be the right word. We are using it very frequently, but handheld devices may not be the appropriate word. The better appropriate will be ultra portable, we can say. So it can be used using it in the hand, and one can shoot the X-ray, but it is better that if it is kept on a tripod, similar to when we do any camera shooting, the tripod can be used. But the size of the X-ray machine is somewhat similar to our very say 6 by 6 inches kind of a thing. It can be carried in the hand. One can go into the community. The some of the issues are if we put it in hand and then there is slight vibration which can actually blur the quality of the images. So it comes with both options of putting it on the tripod and we can put it in the hand. But the plate which is there, that needs to be on the stand. So there is a small stand would be always required to have the film. When it comes to the image processing, it is linked by Wi-Fi or wire with a laptop, and the reading can happen automatically if we use the artificial intelligence. For artificial intelligence for X-ray reading, there are around 2 dozen applications which are validated by Stop TB Partnership, Geneva, and these are available with good quality on a commercial basis. But what I referred to was the one which is already developed by the government of India, specifically Central TB Division, ICMR, and NIC, National Informatics Center, and it is under improvement because the more images you get, the more quality will be, and we expect that it would be patented in next 3 to 6 months, and that will be a big change because then it will be available free of cost, at least in the public sector. And both this together, the handheld, or we can say ultra portable chest x-ray machine along with the AI is if used judiciously, can have impact in terms of additional yield which we are expecting. Back to you.
Thank you, sir. Yes, there are new innovations which are coming in the recent days for elimination of TB by 2025, and we all are working on it. So actually, multisectoral coordination, this is also an important aspect of elimination of tuberculosis by 2025. Sir, any of you, please, can you elicit how IPHA, or we can have a multisectoral coordination for our way forward for eliminating TB or ending TB by 2025?
I would like to take this in a very quick manner, and then I'll request Taufik to add because he is also closely working with us. One big thing which I also mentioned is involving the Panchayati Raj institutions, and this is something which program alone will not be able to do and requires facilitation. So if IPHA can join hands, we can explore the memorandum of understanding if needed with the program, or maybe at the state level, so that you can take up the area and establish the coordination between the program and take up the task of sensitization of the elected members, especially at the village panchayat and the block panchayat and district panchayat, because they are the ones who are going to have huge amount of money which is intended for health and local planning, local implementation, identifying the local gaps. Monitoring at the local level is not just going to be health administration or health ministry, but it is expected to be done by the PRIs, locally elected, this thing, totally decentralized model of governance. And that's where I think rather than looking at hi-fi things like will involve this ministry and that ministry, I think this is one task we can take up in addition to the ITDP, which is the Tribal Affairs Ministry development program, wherein we can do the similar thing, but that is restricted to the tribal. The PRI ministry, which I am talking about, is for the whole country, both rural and urban, and that's where IPH can really play a pivotal role. Back to you.
Actually, I'm taking from the last word from you. Yes, I'm also thinking the same thing, that for the awareness among the people, among the elected representative, we need to work, and IPHA can help in that. So we'll take this decision, and we'll come for your discussion about this. But I felt that awareness among the people about TB and tuberculosis notification, about the free treatment and the test requirement, everything awareness is really less among the people, especially among the not only the poor, especially in the high income group, because still now they are thinking that tuberculosis is a disease for the poor. So it is actually, it's from coming from my clinical setup and coming from my clinical knowledge wherever I'm practicing. So I'm getting this feedback from the people. So this area we have to work. Over to Kaushik.
Definitely, madam. we can work on this area for the elimination of TB and to end TB by 2025.
May I just jump in here because
Yes, ma'am.
we we have to be reminded that it is also the power of your networks. Individual action does matter, and you have connections and you have networks on the ground and you have champions that can champion this further. At the end, it is interpersonal action and the interpersonal communication that will change lives, whether it's the patient, whether it's high income, low income, or the network of people who are training younger generation of physicians. It is the network that, and there's power in this network. Thank you.
Thank you, ma'am. Yes, there is another question. I think this question is also for Dr. Rade, please. That would you please elaborate on radiological exposure to the community around, as there might be no lead welling for handheld X-ray technique.
So there are two aspects to it. Any chest X-ray, if we look at the total radiation which is there per shoot, it all depends upon the configuration. If we look at or compare it with CT scan, one CT scan for an individual is around 1,000 times the chest X-ray. Within the chest X-ray also, it depends upon the total exposure, and this has been certified by the Atomic Regulatory Board, Atomic Energy Regulatory Board, and found that it is not hazardous for the individuals. But on a precautionary note, it is possible at least to avoid any exposure to possibly potentially pregnant females. We can always carry the lead sheets, smaller ones, which are standing ones and which can be carried. But in general, no regulatory board will clear them if they are hazardous. So, of course, the program is cognizant of this fact, and only the ones which will be cleared by the regulatory board will be introduced by the program, and all development partners should also take this point for consideration when they go for this handled X-rays.
Thank you, sir. Dr. Taufik, please. We are coming to the end of this session. And do you like to add something to our way forward for elimination of tuberculosis in India, as you are working on TB since very long?
Yeah, I think most of the things that has been covered, it clearly encompasses everything. So what we clearly need to add IPHS as a network, the way you can work. We need to build up steps and pathways how we can actually. You have, as Pauline ma'am said, you really have a very strong network on ground. We need to actually use it and strengthen it more. So it's not just during World TB, but there must be a way, on a strategic way, and many of you have been involved. We have seen in subnational certification. So we also have to strengthen our pathways and how we can actually come in sync with the national program and state-wise, district-wise. We also have to be strengthened. So this is one important, a very basic step or a step. Most of the things Dr. Kiran sir had already covered. How we can actually move and engage ourselves. These are simple steps which can act and start. These are simple startways, and it can move a long way. Thank you.
Thank you, sir. Dr. Ribu is there with us now. Would you like to add something to this discussion?
No, I have been most enriched by the discussion, and I just hope that this is not a 2-hour program. This is a 3-year or a 4-year program, in which we hold hand together. We have been able to bring the 3 top experts of TB in India, and obviously there are more experts, and we have been able to bring our Secretary General on stage also. So let us start holding the hands together now, and let us start building on a mechanism in which we can play an important role in the elimination of TB, because that is the only dream which we have in our mind just now. So thank you for that.
Thank you. Our Secretary General, Madam, is here with us, Dr. Sanghamitra Ghosh. Please, ma'am, would you want to add something or end the session with the vote of thanks?
But of thanks you will give. I'm just thanking all the speakers because when I welcomed all the speakers that time, I didn't get Tawfiq and Dr. Radhe. So Dr. Radhe will contact you about this IPHA involvement, and we'll take Tawfiq with us because Tawfiq is our member, and I'll urge both of you to be member of IPHA
Ma'am, I
because
am
we
also the
have.
member, though not very active, but
Oh,
I am
really?
also the member. Yeah.
Okay.
And from our side, I have already drafted the key scope of the MOU for 23 associations, including IPHA with the
Okay.
Central TB Division. The moment you
We're
come,
so
we'll take
happy.
it up.
We're so happy.
Thank you so much.
I'll be there. I'll contact you and we'll take you on board and Tawfiq also and Madam Pauline. So
Definitely.
thank you so much for this very good
I just
program.
yeah.
And
So
that all the chats I'm seeing, everybody is appreciating. Thank you so much.
Thank you, ma'am. Thank you all.
Thank you,
Thank you,
Ripu. Thank you,
everyone.
Kaushik.
Bye.
Thank you, everyone. Thank you, Dr.
Okay.
Radhe. Thank you, Pauline Madam. Thank you, Dr. Tawfiq Sir. Thank you, our Secretary General Madam, who has given us all the opportunity for arranging such a beautiful CME, which is one of the best, I think so, in the recent days, with all the stalwarts of TB coming together, the three of you.
and
And I would also like to thank Dr. Pritam Rai and Dr. Anirban Dului, who are behind the scene.
And Shobik,
And Shovik, yes, he's giving us all the technical support.
IPHA headquarter
Yes.
for all the support.
so I just have some submission. It's really, Shanghamitra ma'am, it's an honor. I mean, I shared a screen with my mentor, Dr. Kiran has been my mentor for 12 years or more.
Oh,
And Pauline
that's
ma'am.
great.
So, I mean, to
Fantastic.
be speaking with them, it's an honor for me on a personal note. Thank you, sir. Thank you, ma'am.
It's an honor that we are sharing with three stalwarts of tuberculosis in India.
Not really. We have to work together and make it a success.
Thank you.
Thank you all.
Thank you.
Thank you, the audience,
Thank you.
Thank you.
for your hearing.
Good night.
Shobik, you can
Long
stop
live
stop
IPH.
broadcasting now. Shobik, you can stop broadcasting, please.